I'm going to give an update on the management of acute traumatic spinal cord injury, and from the perspective of what do we know now, and where are we going with this. So I have no relevant commercial disclosures. I have spun off a regenerative medicine a company, but that work is not really relevant to what I'll be discussing today. And I've received grant support from a number of agencies. This is where I work in Toronto. It's a beautiful city, and I hope to see many of you in Toronto. All of you would be welcome to visit us. And I just want to thank my research team, and the gentleman who is standing to my right in this photograph, and to your left is my mentor, Dr. Charles Tatter. So what I'll be discussing is somewhat reminiscent of this Gauguin painting, D'où venons-nous, que sommes-nous, où allons-nous? And the English translation, where do we come from? What are we and where are we going? And I like the theme of this painting, because to know where we are now, you also have to have an understanding of where we've come from, but then it's also important to try to predict where we're going. So in terms of the talk outline, I'm going to talk about the epidemiology of spinal cord injury briefly. I'll review the clinically relevant pathophysiology with a focus on some of the cardiovascular complications of spinal cord injury. And I'll be discussing the non-operative management of spinal cord injury based on the application of this knowledge of pathophysiology. And then I'll be discussing some of the emerging neuroprotective and neuroregenerative approaches. And I'll also be referencing the concept of time as spine. So the idea that early surgical decompression enhances neurological recovery. So there are four main learning objectives of this lecture. Firstly, to apply an understanding of the pathophysiology of spinal cord injury to optimize management. Secondly, to understand the cardiovascular complications of acute spinal cord injury. Thirdly, to have an understanding of the current AO spine guidelines for the role and timing of surgical intervention for acute spinal cord injury. And fourthly, to at least be aware of what some of the key emerging neuroprotective and neuroregenerative strategies in spinal cord injury are. So in this article, a few years ago, we summarized the global prevalence and the incidence of traumatic spinal cord injury. And this is shown graphically in this world map. Now, you'll also see that there are areas that are clearly color-coded, and there are areas where there are data lacking. And we have the best data on centers that have the ability to collect such data. And these are often centers where the rates of spinal cord injury are lower. So the rates of spinal cord injury generally tend to be lower in developed countries and higher in emerging economies. In general, the incidence is around 20 to 40 per million of traumatic spinal cord injury. Now, the causes of spinal cord injury will vary depending on the region of the world that you're in. So for example, if you look at Turkey, it's fairly similar to the rest of Europe and with North America. And so you see that blunt types of injury, motor vehicle collisions, falls, sports-related injuries, and so on are very common. In other areas of the world, for example, in South Africa, you'll see that unfortunately acts of violence, penetrating injuries due to knife injuries and gunshot wounds are commoner. So the types of injuries that we see will vary. What we also recognize is that the epidemiology of acute spinal cord injury is changing. And this is also true of traumatic brain injury. And this reflects the aging of the population. And so I'm sure this is also occurring in Turkey, and it's certainly very prominent in North America. For spinal cord injury, what we're seeing is the overall incidence is stable, but patients are getting older, and there are more cervical injuries and more fall mechanisms. Now, in terms of an overall review of where we are with spinal cord injury, I would commend this review article to you in Nature Review's Disease Primer that our team put together in 2017. And I think that this remains a very good reference. And I'll show some of the figures from this article. So in order to understand spinal cord injury, one needs to have a knowledge of the anatomy of the spinal column as well as the spinal cord. And the types of neurological deficits that occur will depend on the level of the spinal cord. So it depends whether it's cervical or thoracic or thoracolumbar. And then one needs to have a knowledge of the tracts of the spinal cord. Here's an image of a patient that I took care of with a fracture dislocation at C4-5. And this highlights the primary mechanical injury of the cord. There's a contusion, and then there's a progression rostrally and caudally of signal change in the cord. And this is reflective of secondary injury mechanisms. Now, this is a post-mortem section of tissue. Fortunately, not from this patient who survived the injury, but very similar. And this is from Rauchning's collection. So this highlights the constellation of the primary mechanical injury, and there's ongoing compression and instability. And this highlights the rationale for surgical decompression and stabilization. This also illustrates some of the concepts of secondary injury. So you see bruising in the spinal cord and hemorrhage. Now, this is experimental work from our group in Toronto many years ago. And here we injected an animal with colloidal carbon to highlight the blood vessels in the spinal cord. This is the anterior sulcal artery. And then centrally in the gray matter, medial white matter, there is a destruction of these blood vessels. This is a primary damage, and there's hemorrhagic necrosis that occurs. Surrounding this area, you'll see that the blood supply looks less. So this is a lucent area. And this has been referred to as the penumbra zone of ischemia around the injury. And if you stain nerve fibers in this area, for example, for neurofilament 200, you see a progressive degradation of these nerve fibers. This reflects the influx of calcium and the activation of proteolytic cascades, including calpain activation. This is secondary injury. And then this culminates in the pathology of a human spinal cord injury. This is a chronic lesion now. And this is human postmortem tissue. There's a central cavitation. This is where the hemorrhagic necrosis has been resorbed. And this is surrounded by a scar as well as an astroglial response. And then there is a retrograde and an anterograde degeneration of the nerve fibers. So each one of these time points represents unique features in terms of the pathobiology, and as well presents unique challenges in terms of the management. So now I'm going to just review this in diagrammatic format. So here we have the initial mechanical trauma, the primary mechanical injury. There's hemorrhagic necrosis at the injury site. This initiates edema. There's compromised vasculature. There's the initiation of what's called pro-apoptotic signaling. These are gene programs that trigger secondary cell death. And there's disruption of the blood-spinal cord barrier. In the subacute phase, about 2 to 4 days after the injury, we start seeing inflammation occurring. There's release of oxygen-free radicals. There's ongoing edema, there's microglial infiltration. And so there's an attempt by the body to try to repair this initial injury. And there are beneficial effects to inflammation, but there are also negative effects to inflammation. And then in the intermediate and chronic phases of the injury, the necrotic debris is absorbed. And then this is surrounded by this perilesional astrocytic response. This is called astrogliosis. And there's also an inhibitory proteoglycan scar. There sometimes are residual nerve fibers at the injury site, but they're often demyelinated. And this can result in compromise of neurological function. Spinal cord injury can cause significant disruption of sympathetic nervous system. And the neurons in the spinal cord that control the sympathetic nervous system are in the thoracolumbar region of the spinal cord. And so injury of the cervical area and the high thoracic area above T6 can cause significant disruption of the sympathetic nervous system. And this is particularly important in reference to cardiovascular complications. And this could include neurogenic shock, bradycardia, cardiac arrhythmias, autonomic dysreflexia, where you can get abnormal spikes in blood pressure, high blood pressure spikes related to stimulation below the injury site. So for example, a full bladder or colonic distension can cause autonomic dysreflexia. And then there can be venous thromboembolism. It's important to understand the sensory tracts and the motor tracts in the spinal cord, because these can then be referenced in relationship to the syndromes that occur. So there can be a central cord syndrome in which the arms are more affected than the legs, an anterior cord syndrome where there's motor deficits but relative a sparing of sensation, a Brown-Séquard syndrome in which one has almost like a hemisection of the spinal cord with ipsilateral motor loss and contralateral loss of spinothalamic sensation, and a posterior cord syndrome where the dorsal columns are affected, but there's relative preservation of the motor tracts. Patients after a spinal cord injury should be rapidly mobilized to a specialized medical facility with cervical spine precautions, including a hard collar and a backboard. Now, it's important to remove the backboard once the patient gets to the spinal cord center, because a pressure source can occur. So you should not keep a patient on a backboard once they arrive in your hospital. And this is the guidelines evidence to support the fact that patients should be cared for in an intensive care unit or a similar monitored setting to allow assessment of cardiac hemodynamic and respiratory function. The neurological evaluation should be undertaken using the Asia-INSCI standards. And here again, Asia A are complete motor and sensory loss. B is motor loss and partial restoration of sensation. C and D are incomplete motor deficits, with patients with an Asia C having less than grade 3 out of 5 MRC power in the legs. And then a D has key motor groups with greater than 3 out of 5. And then E are patients that had a spinal cord injury but have recovered to the point where they're normal or very close to normal. And then when you should use this chart, which is a standard neurological classification, and you record 5 key motor groups in the upper extremities and the lower extremities. These are graded on the MRC scale from 0 to 5. And then one looks at light touch and pinprick. Very importantly, assess the sacral area. Preservation of pinprick sensation in the sacral area is highly predictive of recovery of walking. And then you get the total motor scores, the total sensory scores. Is the patient complete or incomplete? What's the Asia impairment scale? What is the neurological level for the sensory function, the motor function? And importantly, the zone of partial preservation. This is where you have a partial recovery of sensation and motor function. And in this zone, even when patients have a severe injury, this is often predictive of the levels that will recover. Magnetic resonance imaging increasingly is helpful in terms of informing clinical decision making. So this is the CT scan and the MRI of the case I referenced to before. And this will show the severity and the type of compression and the length of T2 signal change, and particularly if it's associated with low T1 signal change, is correlated with the ultimate outcomes. And we are now witnessing a revolution in the application of more advanced imaging techniques, where we can use these various metrics such as T2, weighted imaging, magnetization transfer, diffusion tensor imaging, and T2 star, white matter to gray matter ratio assessments to define the injury and the preservation of various tracts and circuits in the spinal cord. The hemodynamic management of acute spinal cord injury is an important principle. Spinal cord blood flow is disrupted with critical zones of ischemia after spinal cord injury. And this is the original paper where my mentor Charles Tatter and I described this phenomenon of secondary injury. So we need to treat neurogenic shock. This occurs because of interruption of sympathetics. One can use initially some volume expansion, but you want to be careful that you don't overload the patient. Atropine can be used if there's significant bradycardia, but very quickly you should go to either inotrope or vasopressor support. And in general, norepinephrine has a number of advantages because it has mixed alpha and beta activity. So these are the guidelines: avoid incorrect hypotension and maintain a mean arterial blood pressure at 85 millimeters of mercury for a week after spinal cord injury. Now, respiratory issues are important in spinal cord injury, particularly with cervical and high thoracic injuries. The diaphragm, of course, is innervated through the C3, C5 segments. Injuries at C5 or below will affect the intercostals, and this has an impact on the force vital capacity and the maximum inspiratory force. Months after a spinal cord injury, the chest becomes spastic and rigid, so there's a partial recovery of the FVC and the maximum inspiratory force, but the maximum expiratory force continues to be compromised. It's important to watch out for respiratory failure in acute spinal cord injury. And about a third of patients with a cervical spinal cord injury will require intubation. And the warning signs here are if you see rapid shallow breathing, if you see reductions in the vital capacity below a liter, and in particular, if the respiratory rate is rising or if the PCO2 is rising. And an awake fiber optic technique is preferred. And in the setting of a chronic spinal cord injury in particular, avoid succinylcholine because it can cause hyperkalemia. Quadriplegics are different from able-bodied individuals in terms of weaning protocols, and quadriplegics have better pulmonary mechanics lying rather than sitting upright. And this is because the paralyzed abdominal musculature allow the abdominal contents to descend, and the diaphragm starts in an inefficient position. Now, the use of abdominal binders can help with this. And then there are a number of techniques, including assisted cough, breath stacking, pressure support, and T-piece trials that can be used to assist with weaning. Nutrition is a big issue also in spinal cord injury, which initiates a hypermetabolic catabolic injury cascade, and the energy requirements are significantly higher in a spinal cord injury. And in general, patients require about twice the number of calories. And it's recommended that feeding begin within 2 to 3 days after an acute spinal cord injury, preferably via the gut. Spinal cord injury significantly increases the risk of thromboembolism, and it's important to initiate anticoagulation within 72 hours after spinal cord injury. This is usually done with low molecular weight heparin, although adjusted dose heparin is a reasonable option. and pneumatic stockings can be used in addition. So let's refer to the role and timing of surgery for acute spinal cord injury. And I've called this concept time as spine. And I think that it's important to emphasize the time critical events that occur following an acute spinal cord injury. Now, spinal cord injury is very heterogeneous. Here's a patient with a thoracic spinal cord injury. I've shown this person with a cervical injury. And then there are older individuals, such as this person with an ossified posterior longitudinal ligament who has a cord contusion. But I would argue that surgical decompression and stabilization of the spine has a role in all of these patients. So there's a strong rationale to consider early surgical intervention, and this is to try to mitigate the secondary injury. Now, how early is early? And the reality is that earlier is better, but there are logistical considerations, medical considerations. But in this a survey published in 2010, even at that time, the majority of surgeons would agree that intervention should occur within 24 hours. And this was then later supported by the results of the Staskus trial that we published in 2012. 6 centers in North America, 313 patients with cervical spinal cord injury. And we found that the odds of achieving a very significant improvement in neurological function, 2 or more grades on the Asia impairment scale, was almost 3-fold higher with earlier surgical intervention. So based on this, in 2017, these AO spine guidelines were initiated, which suggested that early surgery be offered as the preferred treatment option within 24 hours. And this has now been further strengthened in this large study that we published in Lancet Neurology last year. And this was in over 1,500 patients. Here on this graph, we're showing the changes in the Asia motor score as a function of time after surgery. This line indicates 24 hours, and you'll see that there's a very steep slope. So there's a clear dose-dependent relationship between the timing of surgery and surgical intervention. On the y-axis here are motor scores as a time of decompression, and the greatest improvement in the motor scores are clustered around this 0 to 24-hour time period. So where are we going now with this time as spine concept? Well, the guidelines that I referred to from 2017 are now being updated based on this evidence, and we'll see newer guidelines emerging later this year. And there's a lot of interest now in considering ultra-early surgical decompression, potentially expanding the dura to allow more room for the spinal cord. And there's a lot of discussion right now in terms of personalizing the approach and providing the correct surgery for the correct indication. So what is emerging, and what other treatments can we consider offering our patients? Well, let's revisit this idea about using an anti-inflammatory, methylprednisolone. And methylprednisolone has been studied intensively in 5 prospective human trials, but it's been a bit controversial because while there are some benefits to methylprednisolone, there are potentially some side effects related to immunosuppression. And so we did a revised systematic review. This was done by an independent group of external methodologists. And this is one of the key graphs that emerged. So these are the motor scores of patients treated within 8 hours of methylprednisolone, the final follow-up of 6 to 12 months. And here is the bottom line. This is the mean improvement with a 95% confidence interval. And this favors neurological recovery. Now, it's been argued that these changes do occur, but they're small. And that's true. But in certain groups of patients, particularly cervical patients, even small amounts of motor recovery can have a significant improvement. So for example, restoration of hand function could have a big effect on patients. Steroids are safe in cervical spinal cord injury. And this was shown here, where there was no increase in mortality and a slight trend for reduction in mortality. So the conclusion here is that intravenous methylprednisolone is a valid option to consider. Depends on the patient, and particularly if you have a younger patient with a cervical injury, I think it's a very valid option to consider. So what's emerging? And there have been a few things that have been tried, shown here in brackets, and unfortunately, these have not worked. But two of the treatments that are looking quite promising are riluzole and hypothermia, or cooling. And riluzole is a sodium glutamate antagonist that is currently used in neurological patients with amyotrophic lateral sclerosis, or ALS, to slow down the rate of nerve cell degeneration. So we're studying this in spinal cord injury, and we're particularly focusing on cervical injuries. Here I'm modeling this with a subaxial cervical burst fracture. The primary injury is amplified by the events of secondary injury. At the microstructural and cellular level, there's a sodium influx, and then this is followed by cell swelling, and then calcium influx through reverse operation of the sodium-calcium exchanger. And there's a pathologic release of glutamate and a failure of glutamate uptake mechanism. So this is what's called the excitotoxic injury. And this is classical in traumatic injury and ischemic injury. So what we've been studying is the combination of early surgical decompression, which I'm illustrating here through a corpectomy and anterior reconstruction, and then we're administering riluzole to try to attenuate the secondary injury. So these are the results of a phase 1/2a matched comparison cohort trial in 36 patients with riluzole and 36 matched controls. And we see that there's about a 25% improvement in the percentage of conversion on the Asia Impairment Scale grade, and there's an improved trajectory of motor recovery. So this was quite encouraging. And then based on this, we launched a phase 3 randomized control trial that we've called RISCUS, and we've just closed out the trial, and we're now analyzing the results. So we'll be reporting on these results later this year. So fingers crossed. And of interest, we reported last year the results of this phase 3 randomized controlled trial of riluzole in patients with a degenerative cervical myelopathy, the CSM Protect trial. And this showed promising results, particularly with reductions in neuropathic pain. Now, hypothermia, or cooling, has been used for millennia to try to treat injuries. But systemic hypothermia is tricky, and there are side effects in the patient that need to be matched against the potential benefits. But nonetheless, in spinal cord injury, if done carefully, it does appear that this can be done with a good degree of safety. And currently, colleagues at the Miami project in the United States, as well as colleagues in Australia, led by Peter Batchelor, are examining the impact of hypothermia in spinal cord injury. So what about neuroregenerative approaches? And here we have the chronically injured spinal cord, and there's a hostile cellular environment which limits cell survival, and there are inhibitory molecules that are expressed which limit regeneration. So regenerative strategies potentially have a role, and cellular therapies are potentially one option. And I'll focus on 3 types of cellular therapies, which I believe show the most translational potential. So one are neural stem cells, Schwann cells, which are the peripheral glia in peripheral nerves, and endogenous stem cells. So this is work again from the Miami project using human Schwann cell transplantation in spinal cord injuries. They showed good safety, although the effects, truthfully, were rather modest. But potentially in combination with neuroprotective approaches, particularly those amplifying cyclic AMP, may show promise. So in this film, I'm just going to illustrate the concepts underlying the use of neural stem cells in traumatic spinal cord injury. So here I'm illustrating the myelinated axons in the white matter. The myelin, of course, is made by the oligodendrocytes, but the nodes of Ranvier are the clusters of sodium channels that will mediate the action potentials. The myelin is attached to the axon through adhesion molecules, including Casper, and next door are potassium channels that shape the action potentials. So after a spinal cord injury, there's a central hemorrhagic necrosis that occurs. And this is surrounded often by some viable tissue in the subpial area, but there's apoptosis occurs in the oligodendrocytes and a loss of the myelin. And then the molecular architecture of the axons is disrupted. And this results in axonal conduction block. And so what's being studied is to use the patient's own spinal cord as a scaffold to introduce the neural stem cells, and then these will go along the white matter niche. And they have a number of properties, one of which is to remyelinate the axons. They can also deliver trophic molecules to assist with the repair and regeneration of the tissue. This is a paper published about a year ago by my colleague Armand Curtin. We were part of this group, and this showed the initial proof of concept with these neural stem cell transplants in human patients. And this is now set in motion further efforts to try to study this with next generation stem cells. And this is an example of one type of next generation stem cell where we have bioengineered the cells to express a growth factor, glial-derived neurotrophic factor. And these result in significant improvements in neurological outcomes as well as electrophysiology. And then in addition, there are stem cells within the spinal cord, and they're in the center of the cord around the ependymal cells. And this could be very helpful for endogenous stem cell regeneration. This was shown as well in this elegant paper in Science about a year ago by Jonas Friesen, who was able to activate latent genetic programs to stimulate these endogenous stem cells. And then this is some work again from our group in which we're modulating glutamate receptors to activate these endogenous stem cells. This is work by Armand Kurt in Europe, taking advantage of discoveries by the basic scientist Martin Schwab in Switzerland and Stephen Strittmatter at Yale to modulate the no-go receptor. No-go is expressed on neurons, is activated by a number of molecules on the disrupted myelin, and this inhibits regeneration. So they're looking at monoclonal antibodies to target this in a phase 2/3 randomized trial. And RGMA is repulsive guidance molecule A. This is another type of inhibitory molecule that's upregulated after spinal cord injury. And AbbVie Pharmaceuticals has initiated a clinical trial with monoclonal antibodies targeting this. This is work from the bioengineer Robert Langer at MIT with neurospinal scaffolds, shown very promising results in animal models. And this is now being moved forward in early phase clinical trials in thoracic injury. And then finally, this concept of bypassing injured neural circuits is attractive. So this is work from Harkema and Edgerton in the United States, in which they've stimulated epidurally the lumbar cord. And this is an area of the nervous system that contains a central pattern generator. And if you stimulate this area, even in people with a severe spinal cord injury, you can elicit activation of the motor neurons and movements and even walking. This is shown here with these EMG records in the lower extremities in a patient who's quadriplegic. And here are some examples published in this New England Journal article of patients who recovered walking ability. And this is work from Europe, from Grégoire Courtine's a group, very elegant paper published in Nature. They're now moving this forward into early phase clinical trials. And these are using brain-spinal interfaces So what they've done is they've used a brain-computer interface to amplify the motor signals from the brain when you're thinking about moving, and this can then transduce movements into the spinal cord. Very cool work. So where are we now and where are we going? Going back to the Gauguin theme of this lecture. So where we are now, time is spine, early surgery for spinal cord injury works. Hemodynamic optimization is critically important. Steroids are an option, and other neuroprotective approaches, including riluzole, are emerging. This should be coupled with active targeted rehabilitation, and electrical stimulation to activate neural networks is emerging as an attractive option. Where are we going to be in 10 years? Well, I think that early surgical intervention will be the international standard of care. There's a lot of knowledge translation that's required here, and I think we'll be able to optimize techniques. I'm hopeful that several neuroprotective options will be validated, and hopefully the results with riluzole will pan out. I think increasingly we'll be looking at personalized medicine, including looking at the genetic signatures that define different outcomes. Work needs to be done on further optimizing hemodynamic management, in particular assessment of spinal cord perfusion. And regenerative options are quite promising, and I'm hopeful that there'll be a number of options available. And I think that electrical stimulation to modulate neural circuits will be a viable option, but we're going to need to figure out how to target this in the correct patient. And of course, all of this will need to be combined with targeted rehabilitation. So take-home messages, future directions. Spinal cord injury results from a primary mechanical trauma, which is amplified by secondary injury mechanisms that include ischemia, inflammation, excitotoxicity, and apoptosis. Cardiovascular complications occur due to disruption of sympathetic neural control. The neurogenic shock requires proactive treatment. Early surgical decompression is critical to facilitate recovery, and future directions will explore promising neuroprotective therapies such as riluzole and emerging regenerative treatments, including neural stem cells. And on that note, I'd like to close out my first lecture, and thank you for your attention. I'm pleased to take questions.
Thank you, Professor. I think the first part is over. There weren't any questions and contributions for now.
No,
We can...
there is a question. There is a question.
Just
oh,
thanks. Thanks.
Dr. Oday wrote to me directly to me.
Okay.
And he has got a question. Sir, open versus miss minimal invasive spinal for spinal trauma. What is better?
Well, I think that the techniques to manage spinal cord injury are evolving. So I don't think it's whether one is better than the other. I think where minimally invasive techniques are attractive is in patients that are frail and have medical compromise. So for example, patients with ankylosing spondylitis, where the bones will heal, but they can have very unstable fractures. So here, for example, particularly for a thoracic injury, one can use percutaneous fixation to stabilize the spine. In other situations, an open approach is preferable in order to achieve a better decompression stabilization.
Thank you, sir. And there is a greetings from Mumbai, India. Dr. Harshad Parekh says regards from Dr. Parekh from Mumbai. Okay, Selim, go on.
And he asked the question after that. You answered in the presentation, but I will read it. What is the role of riluzole? What doses and how long to give? he asked.
So riluzole right now is an option that you can use in traumatic spinal cord injury. It needs to be given within 12 hours of the injury. The loading dose is 100 milligrams, and then it's given 50 milligrams twice a day for 2 weeks after the injury.
Thank you, Professor. And Nurluda Maria from Pakistan. Thanks, sir, for the amazing lecture, she said, and ask a question. How would you modify the management plan for geriatric patients?
Yes, that's an excellent question. So in geriatric patients, one needs to look at the medical frailty. The age is a factor, but the frailty is the most important issue. So if patients are older, but they're healthy, they don't have medical comorbidities, then they'll do well with very proactive intervention. If a patient is older but frail, if they have severe medical problems, then you need to be more cautious. You need to stabilize those medical issues. So for example, it's common for older people to be on anticoagulants, such as a factor Xa inhibitor. Then you need to allow this to wash out of the system. And sometimes, if patients are so medically frail, it may not be wise to operate. So you need to now individualize the patients. But the key issue there is not just age, it's the medical frailty.
Thank you. Another question from Alice Heschel. What do you think about CSF pressure measurement? Further, how do you see dural opening and dural decompression?
Yeah, thank you for those two questions. I briefly referred to those in the lecture. So right now, CSF pressure measurements are under investigation. It's not a standard of care. The idea that Brian Kwan in Vancouver and colleagues, they're putting in lumbar catheters to measure the CSF pressures. If you do that, it's very important that the spinal cord be completely decompressed. Otherwise, the pressure measurements don't reflect what's going on in the injury site. And the idea there is to try to correlate the blood pressure with the CSF pressure measurements to get to optimize spinal cord perfusion. So it's interesting, but it's under investigation. And then duroplasty is being examined by a number of groups. Marius Papadopoulos in the United Kingdom is currently doing a randomized trial where they are examining the effect of opening the dura and then sewing in a patch of tissue to make more room for the spinal cord. So right now we don't know whether this is the right thing to do or not, but we'll see the results of that trial.
Thank you, Professor. Dr. Nana from Georgia said that thanks for the wonderful lecture. Do you use any novel medications, interventions to prevent, reduce post-spinal cord injury spasticity?
Oh, so the treatment is around spasticity?
Yes.
Oh, I see. Oh, yes, okay. So spasticity is an important consequence of spinal cord injury. The spasticity only needs to be treated if it's painful and if it's limiting function, because patients can use the spasticity to assist them with transfers. If the spasticity is painful, then the preferred initial medication is baclofen, a GABA agonist, and usually that can be given orally. In very severe cases of spasticity, intrathecal baclofen can be given.
Thank you, Professor. Dr. Edwin Vasfi from Bulgaria.
Selin, Edwin's question is quite long. Maybe he wants to ask
Okay.
by himself. Edwin,
Yes, sir.
Bulgaria, newbie
Hello.
surgeon.
So my question is, we all know that in cervical spinal trauma, everyone recommends using methylprednisolone. I personally want to know, do you use it?
Yes, I do. So I use, where I would recommend the use of methylprednisolone is in particularly in younger patients with a cervical injury. And the reason is that the complication profile in younger patients with a cervical injury is good. The patients tolerate it well, and even small improvements in function in the cervical cord can be important. So I would use it there. In an older person, or say if someone is quite frail or they're diabetic, I would be careful because the secondary effects, complications of methylprednisolone outweigh the benefit. So this is a case where what we've said is it's an option, but you should then consider what is the right medication for the right patient. And this is what I'm getting at now. I tried to emphasize this in the lecture to try to individualize the treatment. Not everything is correct in every patient. You want to then understand the principles.
Thank you, sir. And I have a second question. What about the central cord syndrome? Some people say make surgery, others say just follow and treat them conservatively. What do you do?
I operate, so I will tell you that, and they benefit from surgery. The patients who have a severe central cord injury, an Asia C injury, do better with early surgery. The patients with a milder injury benefit from surgery, but there it's a little less critical to do it within the first 24 hours. I usually do those patients within the first few days after injury. Sometimes though, if the patients are older and they have medical frailty, then you can't operate in the first 24 hours. You need to stabilize the patient first.
Thank you, sir.
Thank you.
There is a message from Professor Halukberg. Thank you, Dr. Fehlings, for this excellent review. Always a pleasure to listen. The latest timing studies reveal the importance of early decompressive surgery. Is there a difference in recovery after cervical and thoracic cord injury?
Yes, there is. Each level will be different, but early surgery is effective for both cervical and thoracic injuries, even for thoracic Asia A. So the outcomes, the conversion rate for a thoracic Asia A injury is lower than a cervical Asia A. We know this. So the benefits of surgery for cervical injuries are clearer than for thoracic, but there is a benefit for thoracic injuries.
Thank you, Professor. There's a question from Dr. Narayan Swami. Can we use newer drugs in combination with stem cell therapy, or will it have to used one by one?
Yes, thank you. Well, right now, stem cells are under investigation. They're not a standard treatment. I hope they will be, but right now they are not. So that's one point. Secondly, could we be in the future looking at combinations of treatment? So for example, early surgery, riluzole, maybe neural stem cells, maybe together. Yes, I think that what will be required, and this really will be the art of medicine, is to try to find the right combinations of the treatments for the patients. Right now, however, we're studying them one by one, And then in the future, if we have some effective options, we can look at the combination, of these together.
Thank you, Professor. Dr. Serdar Solmaz asked that, what do you think about the timing of stem cell injection, intra-op or post-surgical?
Yes, so that's a good question. Again, just to emphasize, this is an experimental treatment, but here's what I'm thinking. I think that in the subacute to early chronic phase, so within 3 to 6 months after the injury, is a good time to consider the use of neural stem cells potentially in the future. And the reason is that the patients are stable after the injury. 2, you have a good idea where they're going. So if a patient is showing a good recovery, you don't want to use stem cells. But if a patient is showing a lot of neurological problems, then it's a good option. The second group of patients will be those with a more chronic injury beyond 6 months. That's a big challenge because of the scar tissue in the injury site. So there, we're going to need to be using stem cells in combination with growth factors or factors to degrade the scar tissue.
Thank you, Professor. Dr. Harshad Parekh asked that, have you tried stem cells in human spinal cord injury?
Yes, we have. Only in the trials. So I refer to the publication that I did with Armin Kurt, where we reported. So the results showed that it was safe, no serious complications, but the benefits were very small. So we're using this now to learn to improve the stem cell technology, and secondly, the type of patient. So we were probably studying the stem cells too late after the injury. The type of stem cell we were using probably should have been done around 3 to 6 months after the injury. For more chronic injuries, say a year to 2 years after, again, we need to use stem cells in combination with medications to reduce the glial scar.
Thank you. Dr. Baran Taşkalı from Istanbul said that, thank you, Professor. What do you think post-surgical MAP CSF pressure monitoring?
Yes, so thank you. So again, this is similar to the previous question that I was asked. So right now, the guidelines indicate maintenance of mean arterial pressures of 85 millimeters or greater for a week after spinal cord injury. And that's the principle that we should use. What's now being studied are techniques to optimize this. So maybe CSF pressure catheters will be helpful. It needs to be studied. The idea trying to individualize this and to look at targeted treatments similar to traumatic brain injury.
Thank you. And another question from Dr. Baran Taşkalı: how do you decide to cranial or caudal border of decompression?
Okay, so that is based on the MRI. And what we have learned is that it is important to decompress the full length of the injury. Bijan Arabi from Baltimore, Maryland, has been big into this area. So the MRI is important. If you don't have an MRI, then the CT scan will give you a pretty good idea. But what we have learned is that the spinal cord can become quite swollen. So for example, if you have a facet dislocation in the cervical area, I often will treat this through an anterior and posterior approach, an anterior reduction, discectomy, fusion, but then a posterior laminectomy and lateral mass fixation.
Thank you, Professor. And there is a question from Dr. Nana, about spasticity. Maybe the spasticity is not painful, but reducing spasticity could be helpful for successful rehab. Don't you use anything for less painful cases or for prophylaxis?
Yes. So again, the spasticity can be helpful also for transfers. So I think the key here is, one, is the spasticity painful? What about situations where the spasticity is interfering with function? Then yes, treatment of the spasticity there would be helpful. The learning point, though, is that just because you see increased tone, you don't always have to treat that, okay? Because there can be a benefit to the spasticity as well.
Thank you. Dr. Mustafa Ağoğlu said that great presentation, thank you. Dr. Harshad Parek asked, how do you produce stem cells?
Oh, okay. There are various ways to do this. Previously, these were made from embryonic sources. This no longer is required because of a major discovery made by the Japanese researcher Yamanaka. Yamanaka received the Nobel Prize for the discovery of what's called induced pluripotent stem cells. What you can do is you can take a cell from the patient, say even a skin fibroblast from a small skin biopsy, or cells from the bone marrow, and you can reprogram these by introduction of transcription factors. And you can make the somatic cell revert back to a pluripotent stem cell. And then by using special programming approaches in culture, you can then make neural stem cells. And you can design these so that they're very safe. They won't become cancerous at all. And so you have really beautiful control of this. And what's very appealing, say, from a surgical perspective, is that the cells can be matched to the patient. That's a big advantage. And then secondly, you have very precise knowledge on the genetics of the cell. There are no tumor cells. There's no possibility of making the tumor. So this is a big advance that's occurred. What the scientists are now working on are more efficient ways to make these stem cells. Right now, it is still not as practical and as efficient as it could be, but there are rapid advances that are occurring, for example, through roboticized techniques. And so the idea here will be just like, when you get an antibiotic drug, every time the drug is the same, you want that same type of good manufacturing protocol control over the stem cells. You have very precise knowledge. So there have been very major advances that have occurred in the last 10 years in the stem cell technology.
Thank you, Professor. Two questions have left. Dr. Nara asked, have you ever tried the stem cell for degenerative spinal muscular atrophies? I'm considering for pediatric case of spinal muscular atrophy with respiratory distress.
Right. So now you're going outside of my own scope of practice. So I personally don't treat spinal muscular atrophy in children or adults. There are some early phase trials that have occurred for both pediatric neurodegenerative conditions and also in adults with ALS. Right now, the trials have not shown great results, but there's a lot of research that is going on in these areas.
Thank you. And Professor Bektaş Açıkgöz said that, thank you, Professor, for the excellent presentation. What is your strategy in deciding surgery for chronic patients?
For chronic patients?
Chronic.
Chronic patients.
Okay,
Chronic.
with a spinal cord injury.
Yes.
Okay, very
I
good.
think.
Yes, okay. So the main situations there will be to treat the complications of a chronic spinal cord injury. So from a neurosurgical perspective, one complication can be syringomyelia. This is a cystic degeneration in the spinal cord, and that can result in delayed loss of motor function, spasticity, pain. And so there, the treatments would involve decompression of the spinal cord if it's compressed. Sometimes if you can open the dura to expand that, and if that's not effective, you need to place a shunt catheter into the syrinx to drain this. Sometimes patients can develop a deformity of the spine. So for example, children with a spinal cord injury before the age of 8 have about a 90% incidence of developing scoliosis later on in adulthood. They may require correction of the deformity. Another area to be aware of is that patients with a spinal cord injury are much more likely to get degenerative disc disease and degenerative spondylosis. So for example, patients with a high thoracic spinal cord injury may develop cervical myelopathy above the level, and they may require decompression later on. We're now learning about this. So spinal cord injury has lifelong issues, and these patients do require follow-up by a physician who is experienced in the management of this. So if your medical system allows for this to occur, optimally the patient should be regularly followed by a spinal cord injury team. I realize that's not always possible, but that is the ideal circumstance.
Thank you, Professor. And the last message from Ömer Alamar. He sent regards.
Okay, Selin. I think we have finished all the questions and comments.
Yes.
We can go on, continue, I think.
Second part.
Right. Okay. So I may not have enough time today to give the second lecture. Just as you know, we had a bit of an issue with the time zone a change. So I could do one of two things. I could give a very small version of the talk, but I don't think there will be enough time for me. Or if you are open to this, I can schedule a time for the second talk, and then we could do this
later.
Perhaps give it more time.
It will be perfect. So we can decide the date and time.
Yes, I think that would be. I think that would be better, and then then I could give the full lecture and then allow a good discussion.
Yeah, it will be better, as you say.
Yes. Okay. Yeah. And sorry about. Yes, in North America,
it's my mistake. I didn't.
No. It's okay. It's okay. These things happen all the time. No problem. No problem. It's we changed the times because of what's called daylight savings time.
I think yesterday, is it right?
No, it was in Canada, at least, it was March 13th. But that's one of the other things as well. It's different around the world. It's a very old-fashioned concept, but it is what it is. Okay. Look, we will schedule another time. Very happy to speak with you.
Perfect. The question and answer section is was quite long, which is good thing for us. And 128 people joined us today for the meeting. And I want to invite all of you to our second meetings also with Professor Michael Fehlings. Today, I want to thank you again, Professor Fehlings. Thanks for accepting our offer to speak in our conference. Today is a big day for İzmir Online Neurosurgery. We listen to most prolific expert by far in the field of neurosurgery in the world. He is also most prolific expert by far in the field of spine surgery in the world. He has 17 publications listed in the Web of Science. These are SCI publications that are considered being high quality. The total number is much higher than this, but I do not know the exact number. He probably, Professor Fehlings probably doesn't know either. And he has probably stopped counting. I hope one day we will have the chance to see him face to face and to host him in İzmir. I would like to thank everyone who attended and contributed to the meeting. Okay. Good evening.
Thank you very much.
And
okay.
Good morning. Wherever.
Bye-bye. Until next time. Thank you. Bye-bye. Bye-bye.